we've always got to remember the flip side. I was standing outside an empty isolation ward at a hospital I used to work at here 12 years ago, and it's empty, pretty empty. And on the top, it's got a list of the diseases that come into the ward, and it's like cholera, mumps, measles, diphtheria. And the reason there's no one in it anymore is because we've vaccinated our way out of it.
Hello, and welcome to The World Can Be Better. I'm Frances Lorenz, and I'm co-hosting with Toby Tremlett. Hello, Toby.
Hello.
And today we are interviewing Nick Laing. Nick is the co-founder and CEO of OneDay Health, a charity which starts up self-sustaining health centers in northern Uganda. You might also know him from the Effective Altruism Forum, where he's written some great posts on a ton of topics, including water chlorination's surprising impact on reducing child mortality, the possible effectiveness of menstrual cups as a health and well-being intervention, and what NGOs in Africa can do better. We'll discuss all of these ideas today, and we're very excited to have you, Nick. So thank you for being here. Yay! So just to kick things off, I kind of just want to ask, what made you want to get into the nonprofit space and try to do good with your life? And what makes you want to continue doing the work that you do?
Yeah. Awesome, Francis. I'll just tell a bit of a story here, if that's okay. I was a really immature 18-year-old. Like when I was 16, I wanted to be an engineer, but I did so badly at calculus, I'm sure some people can relate, that I ditched the whole engineer thing, decided to try and go to medical school. And in my first year, I had these tutorial groups every day of the week apart from Tuesday. And on Tuesday, there was this justice Bible study that I was a part of. And on the first night, there was this question I'll never forget. And the person who was running it said, "I'm running this fundraiser for World Vision, and I just offered my heavy smoker friend a pack of cigarettes if he signs up to fundraise. Is that a good idea? Should I have done that?" And so we talked for an hour about whether it was going to be the right thing, the trade-offs between the cigarettes and helping the poor children. And that was awesome. But the group didn't just talk. So we'd go to this kind of soup kitchen on a Friday night, mini soup kitchen thing. And most of the people who came to get food had these lives which were so much rougher than mine. Like their parents maybe weren't around much when they were young. They just got really unlucky with severe mental illness. And this just made me so grateful for my kind of very loving but fairly standard middle-class upbringing. My parents were amazing, gave me lots of opportunity, and like what an incredible time of history that we can be like fairly average in our country but still have so much opportunity. And there's two interesting things that really stick with me, like why, things that Jesus said, which I think apply to everyone. But one is that freely you have received, now freely give. And so this is this gratitude, like I've received so much, and like how can that go back out? And when I was 16, 18, I wasn't thinking about that, and this group helped me think about that. And then kind of the flip side is, to whom much is given, much is expected. So there's this like responsibility that's layered with the gratitude. And there's kind of tension between gratitude and responsibility. And I think a lot of people who try and do good feel both of those things. Mm. And that's really what drives me, is this combination of being so grateful, but also like, holy crap, like this is, I've been given so much. And so many people just haven't. I mean, here in northern Uganda, it's just crazy. I always say in northern Uganda, if Einstein were born in the village 100 times, we would never know, which is a sad truth, I think, here. So yeah, what can I do about that?
Yeah, that kind of the idea of like having the privilege and that being the reason that you have to do good is, if you go on Giving What We Can, they have a page where you can see the explanations people give for their pledges, and that's one of the ones that just pops up like all the time, is people just being like, "I'm so grateful," or like, "I'm so lucky I've got to give back." And yeah, so it's interesting that you found it through this particular class, but it looks like people find it in like many ways as well.
100%. There's a lot of ways people find that. And I love their, I think it's them that have that thing where you spin a wheel. It's like, where could you have been born in the world, It's like, oh my goodness, because most of the time, a lot of people spinning that wheel, most likely it could have been a lot rougher, And so that's again, gratitude, responsibility. But yeah.
Totally. And then just to give context, so Giving What We Can is a nonprofit that encourages people to pledge 10% of their income to donating. And so then a lot of people who take this pledge like donate to things like global health.
Mm.
Um, Also, maybe a bit of a tangent, but the Einstein point that you made, Nick, is really interesting because I remember I used to think, oh, yeah, of course, like if you were to grow up without resources, it would just be impossible to, I mean, do some of the things that like a lot of us in sort of middle class and developed countries can do. But not only that, like just when I realized how different the under five mortality is in like still developing
Mhm.
countries, like so many people just never even get the chance to grow up at all. And it's just, yeah, I don't know. Yeah, it's really like sad, like to understate it. But yeah.
Yeah, it's it's
Uh,
it's it's sad, and I mean, we've always got to remember the flip side. I was standing outside
Mhm.
an empty isolation ward at a hospital I used to work at here 12 years ago, and it's empty, pretty empty. And on the top, it's got a list of the diseases that come into the ward, and it's like cholera, mumps, measles, diphtheria. And the reason
Mm.
there's no one in it anymore is because we've vaccinated our way out of it. And so, like, again, I think it's really important. Like, yeah, things are really
Yeah.
bad in Uganda. They were a lot worse not that long ago. And it's really, really important to recognize. I mean, like, we don't have cholera outbreaks in northern Uganda anymore,
Mm.
and that used to be, that's on the wall of this ward. And it's now irrelevant. There was these beds in this ward where it like literally has a hole over where your bum is because that's cholera.
Mm.
And the bed is still there because it just
Wow.
runs right through you, right? And it's just, it's a great reminder that things are getting better. But right from the bottom, like you said, the hard things, the higher mortality, then through to the top. I mean,
Mhm.
the uncomfortable truth that we don't see, Nobel science winners, coming from education systems, and so
Mm.
all the way through there is this huge, huge disparity.
yeah, totally. Oh, that's really like lovely though to hear about like yeah the wins too and like the good things that are
Mm.
happening, and that kind of leads perfectly into the question of what inspired you to start One Day Health, and could you just tell us a bit more about it in general?
Yeah, I mean, I've been in northern Uganda now for 13 years, and
Mm.
really it was just like a response to a local problem. We were I was managing bigger health centres, and we'd drive on the roads between these bigger health centres, and we'd come across people on the road, and they'd be like, "But that health centre's 8 kilometres away. What about us here? What can we do?" And so I kind of started with me and my friend Emma, who's a nurse. We were working together, and we were like, how can we do something about this issue? So we kind of crowdfunded,
Mhm.
I think like $9,000, and we decided we'd set up like what's the simplest way that we can
Mm.
actually provide comprehensive healthcare here. And that started. But I could kind of step back and look at the issue that we're solving. Like when I was young, I used to get asthma a lot, and I went to hospital 3 times, but I was always going to be completely fine because there was a great
Mm.
hospital like right there. And in remote rural Uganda, it's different. There's a woman I've come to know a bit called a Callow, and she lives in what we call a healthcare black hole. And when her twins get a cough, unlike me, it's a completely different situation. She can walk 12 kilometers to a distant health center, or she can sit at home and wait and hope. And I'll never
Mm.
forget, she looked me in the eye this one time and said, Daktar, tuo dong pe quoro, which means sickness doesn't wait. And that's the
Mm.
reality for so many people. There's 100 million sub-Saharan Africans who live too far from good healthcare. So what we do is we put one nurse in one room who for the first time provides good healthcare in these what we call these healthcare black holes. And our
Mm.
process is fairly simple. It's we find the healthcare black hole, then we put the one nurse in the one room. So we use a tool where we map all the current health centres. It's a really
Mm.
cool tool, actually. And then we find all the places, the population of 3,000 to 5,000 people who currently don't have healthcare around. And then we train one nurse to give comprehensive healthcare. I like to say she can probably do more in these tiny rooms than your GP can in England. That might be
Mm.
a bit rough, but they can do quite a lot. And then third is the room. Like we equip her with everything she needs in this rented room. So like the
Mm.
beds, the tables, the chairs, the drug cupboard, and the solar unit, medicines, and then we pack it all onto a truck, take it out into the village, and we launch in one day. And what I like to say is this is my bold claim is it's like some of the cheapest healthcare on earth at around $2 per patient for most for that's the average cost for
Mhm.
our patients. So yeah, so we've got 88 of these around. So we started in the north, but we're actually all around Uganda now, which is cool.
Mhm.
And in the last kind of 8 years, we've treated 400,000 patients. And this year, we're on track to treat 150,000. So yeah, it's been a big last couple of years for us. So anyway, that's probably more than you wanted to hear, but that's
Wow.
like my little
No,
background about OneDay Health.
It actually isn't. I have a lot of questions about this. Yeah, one of them is like, where do you find these nurses? It seems like such an intense thing for anyone to do, right? To move out kind of into the middle of nowhere from their perspective and be like an extremely responsible figure then in a community. It just feels like each of those people must be quite special. How do you find them?
Yeah, I mean, first, there's a bit of there's kind of two aspects to this, I think. First, there's a bit of a myth that there's a shortage of health workers in a lot of sub-Saharan Africa. Like, actually, in most countries, there still probably is an overall shortage, but in most countries, there's tens of thousands of unemployed health workers. So there's actually a surplus in terms of jobs. And this is why you might have heard of some of the big immigration programs. There's actually just been $100 million fund. When they don't have any money yet. They have some money, but set up to try and help, especially medical workers who are trained but move to places like Germany and England to get, to be able to get jobs. But in Uganda, there's maybe 15,000 unemployed nurses. And so we pay them more than they could at like a drug shop or a clinic. And we often give them their first or second kind of real job. So finding nurses is not hard. Like we get 20, 30, 40 applications. We interview 10, we hire 1 or 2. So nurses, there's just so many unemployed nurses. And in a lot of sub-Saharan African countries, this is the situation. But on your question about it being hard, it's just 100% true. Like, they're educated people, right? And then you're going out to this remote village where often you're the most educated or the only person who has like a tertiary. And when we when we ask our nurses, what's the hardest thing about being out there? They don't say, well, when a patient comes in and they're nearly dead and we don't know what to do. They don't say like, oh, when people come in and they don't have the money to pay and we don't know what they tell us. Their two hardest things, their hardest thing is loneliness. Like, that's the hardest thing about being out there. Right. So you're absolutely right. That is a big issue. But our nurses are like, love working in these communities. They're really grateful to have a job, and we really support them with training and education and supervision to try and up their skills and take them to the next level. Yeah.
You give this figure of $4,000 for setting up each of these like ultimately self-sustaining clinics. How is this possible? This seems obviously from a Western perspective, but it just seems like a very small amount of money. Yeah, how do you do this?
Yeah, it's a good question. The big thing is that we rent, not build. So that's like the number one factor, right? And it's actually only $2,000 is for setup, and $2,000 is like a buffer after starting. So the setup cost is actually only about $2,000. So $1,000 is medication, $1,000 is medication, about $500 is furniture, $150 for a solar unit, and then some change. So sometimes we do some small renovations. So we have a rule now that we have to have a cement floor. At the start, we were doing some with dirt floors, but it's not the greatest hygiene. So I mean, it's just not that expensive to get the basics we need for comprehensive healthcare here. Part of it is that medication has got a lot cheaper. So all of our medications like imported from India that's made en masse, and often for a box of 100 tablets of amoxicillin or paracetamol, things like that, it's kind of like $1 or 50 cents or $2 for a box of 100 tablets. And so a big part of the setup cost is the medication and tests. Another big innovation is the rapid tests. I'm sure you've seen the rapid tests for COVID, the classic ones like for pregnancy.
Yeah.
So now we have these rapid tests for malaria, for hepatitis B, for syphilis, and obviously the urine test, pregnancy. And so this is what makes OneDay Health possible. It would not have been possible when you had to look down a microscope for malaria, right? Because then you need someone in the laboratory. And these tests are often like between kind of 50 cents to $1.50. Like a urine test is like 4 cents to actually do a urine dipstick with 9 parameters. So like just the plummeting costs of these basics of healthcare is a big part of what makes this possible as well.
I was just thinking as well, I feel like a question, when you're first hearing about this, kind of one of the first questions that came to my mind, I was just remembering, because I heard about this a while ago, but I think at that point, I was wondering, what percentage of cases that present in these clinics can you solve with a nurse in a medicine cabinet, because it's quite surprising. Presumably that would apply to the West as well. Like, we go to a GP who is a trained doctor normally, but you can also go to a pharmacist for most things. What percentage of cases that present at the clinic can you answer and solve with the nurse?
Yeah, so it's about 95%, so kind of 19 out of 20 cases. So we treat the conditions is about 35 conditions. So it's completely standard, right? These are the conditions we expect you to be able to treat, and then we support you to treat those conditions. But also very important, and of the common ones, which won't surprise you, number one's malaria, number two's the common cold. Then we have pneumonia, skin infections, urine infections, sexually transmitted diseases, and then chronic conditions like diabetes and high blood pressure, then like family planning and pregnancy care, so antenatal care, all that stuff. But then when there is a severe condition that needs referral, and that's very, very difficult, because when we're in this remote place, we're not just referring them to the health centre 7 kilometres away, because we can do at least as much as that. We're usually referring to the hospital 40 kilometres away, like an hour or 2 hours. So it's a long way, and that's very difficult. But the good thing is we can often give pre-referral treatment. So we can give some IV fluids, we can give the IV malaria treatment that's intravenous, we can give the intravenous antibiotics. So we have this pre-referral treatment, which at least buys time. But like one thing which is relatively unsolved is the referral problem. So there's a lot of people talk about referrals and how we fix that. But like at the end of the day, in most of these places, a referral is, well, here's a motorcycle, and they have to pay a lot of money for it to get to a faraway health centre. And there's just no way around that. Like, these are places where ambulances wouldn't reach, but it would also just be far too expensive, even if they could. Like, the referral problem for those cases that need that is, and it's really hard because often the patients refuse to go. Like, we've had a 3 or 4 snake bite deaths in our facilities because the nurse was saying, you have to go. And it's pouring with rain. No motorcycle will take them. We don't have a fridge, you see, so we don't have antivenom. Even if we did, 1 vial of antivenom is $200, And so, like, there's some problems which are just a nightmare. Like, I love the initiative. There's a great initiative, which was, they talked about on the Effective Altruism Forum, to make cheap antivenom that doesn't need a fridge. Like, it feels like it must be doable, but like, if you could give us cheap antivenom that doesn't need a fridge, that would be amazing.
Yeah. Okay, cool. Something else for the medicine cabinet.
Yeah, a lot of things. I can make a drop down list. We'll send it to the drug developers. And I mean, genuinely, it's like this is where these people, you've heard about these like advanced market commitments. Like the malaria vaccine was a revelation. I mean, we could have made it probably 30 years ago, but it took Bill Gates and a bunch of other people to say, hey, if you make this thing, we'll fund it to roll it out. And then within 5 years, we got two vaccines. Some things are not that hard to do. It's just that the motivation is not there to do it. Yeah.
Or like the market incentive. So it's like good when groups can step in and say like, okay, we will make the incentive, right? Yeah.
Yeah. It's like if you do this, we guarantee that we will pay for it, right? Because drug companies are prepared to take a risk, but they're not prepared to take a risk if no one's going to pay for it, even when it does come out. The craziest one like this is, I don't know if you heard about this potential TB vaccine, which a drug company did a trial on, and it worked in the trial. And they were like, that's cool, but it's going to take us 15 years and $400 million to actually figure it out. So we're not going to do it. And so I think the Gates Foundation and the Wellcome Trust actually bought the rights to this and are doing that trial, which will take... So TB's a really slow disease, so it takes you 10 years to do a trial on it. It's not like malaria when you can do a trial on it in 6 months, really. So it's crazy the financial incentives. Like, humans can do so much to make the world better if the money is there on a plate. But if it's not...
Well, I looked into this a while ago as well, and the other factor here is that once the company actually produces the vaccine, it's the incentive of governments to like push the price down as much as you can, because you don't want to, and publicly it's like, this company is charging this much for the malaria vaccine, people are dying of malaria, this is evil. And understandably, but also, if you want a malaria vaccine to be invented, that someone needs to get paid at some point. So I love the idea of just paying them up front at the start. It kind of feels like this would sell better to the public as well. It just makes more sense that people are just investing in this vaccine. Yeah, rather than
Yeah,
this
and I mean,
weird dance that everyone has to do at the end.
It's true, but you don't even have to always pay up front. So they're not paying up front. The Gates Foundation just says, if you make it, then we will roll it out. So that you don't even need to take the risk for these market commitments. The drug company's still taking the risk. You're just guaranteeing the money at the end of it, which is kind of the cool thing about it. Yeah.
Yeah. I kind of also wanted to ask, what is the salary of the nurses, if I may?
Yeah, no, sure, of course. No, everything's there. It's an awkward question because it's very low. So it's about $150 between 130 and 150 US dollars, which is more than it's like 30-40% more than they'd be making in any private market. The people who pay more than this are governments and big NGOs, basically. And so what our system is we say, come to us as a first or second job, we'll train you, and then within kind of 2 to 5 years, there should be an opportunity to get like a bigger job. Unfortunately, this is our pathway and this is what we say, but the market has been so bad the last 3 years with USAID going down, with a lot of like the Ugandan government hasn't been hiring people. So at the moment we've got amazing staff retention, but it's actually not good. Like I'd rather have worse staff retention, but our nurses actually moving on to better jobs. So we can promote the best ones to managers. So we have 88 nurses and then 10 managers kind of on top of that. But we can't promote much further than that. And so it's just really, really hard. And yeah, there's a really awkward inequality of salary. But I really want to say, I think it's very bad, which a lot of NGOs do, to come in and distort the market. And I think I call it, and this is controversial, but I think there's a lot of white guilt that comes in and says, oh my gosh, $150 a month is so unfair. Yeah. That's ridiculous. How could we pay that when I'm in on my, like $10,000 a month Western salary or whatever it is. And so then you distort the market, and then you cause local inflation, which has happened a lot actually in my town that I'm in, and Gulu, which is now the most expensive town in Uganda, I think partly because of NGO inflation. And so then if you're a poor person, everything else is more expensive. So salaries are a very difficult thing. But like if we want to make these things sustainable, we have to be within the local market. Like how else do you operate apart from within you can't manufacture money out of nowhere. Yeah,
that's another part of the process, right? Because I was wondering when I looked at this like $4,000 figure, and I think Francis is going to ask some questions about the cost effectiveness stuff in a minute, but one of the aspects there was that the clinics become self-sustaining, so people do end up paying for their treatments, which it's just interesting to me because the start of the kind of argument that you make is often that people can't afford to pay for medicines and stuff because it would cost them several dollars, and they don't have a lot of dollars to throw around. How does this work? How do people how does it work out as enough money that you can sustain these things?
Yeah, this is a big question that we could do a whole hour-long thing on. But First, I don't think I've ever said that people don't have $1 or $2 in my opening spiel. I think you've read that into it.
It was something like it was more that when you're earning $50, the decision to spend several dollars on medical treatments is a major decision.
Yes.
Yeah, I think that was basically a summary.
100%. I mean, so there's kind of two aspects to this. One is that our patients tell us that they save money because when they have to travel to a distant facility, they're spending kind of $4 to $6, and with us they're spending $1 to $2. So, and when we ask our patients, are our costs reasonable? Over 90% of them say that our costs are reasonable. Now, of course, that doesn't mean you can afford them. Just because you think it's reasonable and it's fair, that doesn't mean you can afford them. And this is a constant battle in healthcare. So, famously with mosquito nets, they did a big study that looked if people pay for them, how much of a difference does it make to usability? And basically it came out if they're free and you give them to people, then far more people take them and use them. And it is true that people paying even $1 or $2 for OneDay Health will stop some people using OneDay Health. But I think it's a pretty low proportion of people. We're actually doing a study at the moment with Princeton University looking at this, which is really interesting. So we're giving vouchers to some villages where instead of paying $2, they pay 30 cents. We're calling it the almost free voucher. They wanted to make it free, actually, and we were like, if you make it free, there's going to be a stampede on the health centre. But But yeah, so what we're trying to do is see that who are the groups who are not coming, like who maybe this money could be restricting. Is it teenage girls? Is it older people? Is it kids under 5? And then maybe for that 10-15% of the population, we can give a concession. We can make it half as expensive for them. So it's also going to tell us, like, are people actually coming in later for malaria? So when we compare the voucher patients to our normal patients, do they have less severe disease? And it will say, like, okay, maybe this issue of payment does have a big issue. But we know that payment does stop some people from coming, but I don't think it's so many. And you balance that with sustainability, right? So that we can spend most of our money on launching, because at the moment it's about 80%. As a network, we're about 80% kind of self-sustaining. Some of the facilities are making a small profit, some of them are making a loss, some of them between. But what that allows us to is to use that extra money that comes in for growth and for launching. I mean, also, another thing that money does, it gives you a really good feedback mechanism. One of the worst things, and I saw a great post by this actually from Joey Savoy, is that NGOs just don't get feedback from people, right? Because you're doing everything for free. So how do you actually know if people are appreciating what you're doing? Like I'm a big survey skeptic. You can do a survey, but I'm a bit of a skeptic on that, because people are going to be like, yes, great, just give stuff, like whatever. And it's hard to get the truth, I think. And so you get really good. If no one's coming to the health centre, well, there's a big problem. And the nurse isn't providing good treatment, people aren't happy. And so I think feedback is actually a very important mechanism and advantage to having these patient fees. Just finally, we also have standard fees, so that no matter where you come from, you know that if you're under 5, you're paying $1. If you're over 12, you're paying $2, no matter what your condition is. So you come with that money. So you know if you're 7 Ks away, you get sick, you know that if you come with $2, you're going to get all the treatment that you need. And that's very important for people. And that's quite unusual. Most places don't work like that. You turn up and then you have no idea. But that massively demotivates you to come, right? Because if you think you don't have enough money, well, then what's the point? At least with us, that if you have this much money, it's okay.
That's like extremely interesting. Yeah, there's this like thing with talking about poverty, where obviously the reason poverty is bad is because it's just unfair and people are suffering, and that is horrible. But then there is also this sort of other like point of like, if people can't purchase things, you are missing an extreme amount of information about what they need and what they value. And so there is something kind of to the conversation people often bring up about like agency and like making sure that you're not just like kind of bulldozing over a community. It's like when you give people like purchasing power and they can actually show you what they want, like this is valuable in a way that, surveys are not, because like you said, you can ask anyone anything. I'd answer all surveys. I just lie all the time. Cause
what? Why, Francis? That's terrible. Why would you do such a thing?
You?
Yeah, I hate to like bring it up like this, but I don't know. I just hate surveys. They always say just ask you questions, and you're like, I don't know. You know what? I love it. Or you're like, I'm like having a bad day.
So it's that you can't. So you answer better because you can't be bothered, not because you want to make them happy. Or like a bit of both, or what is it?
Yeah, or it's something of like just like panicking, like some weird thing of like, oh, I don't know my answer. Like I'll just whatever. It's just like
C. It's always C. I pick C. Sorry.
Yeah, like performance anxiety or something. Like, yeah. And then there's like, anyway, okay, I don't want to get us on too much of a tangent, but there's this other thing too that I think you've touched on of like treating people in poverty like they're not normal people, which is like we all just like make weird choices or like hate surveys or like find things aversive. And it's like so easy to say, oh yeah, just like go walk 2 hours. Who walks 2 hours anywhere? Like no one does that. Like I don't know why somebody in poverty would be like, you're so right. Let me just put on my shoes and go for a nice hike. Like it's like, yeah.
And I mean, when you're really sick, or your kid's really sick, it's just really hard as well. Like malaria is nasty, right? And so like part of it is like, why would you do it? And part of it's just that like it's sometimes close to, I mean, I was talking to people in Malawi when I went there, and this one woman's like, yeah, the health centre was 10 Ks away. I walked 3 Ks, I got too sick, and I just went to sleep under a tree. And I woke up in the morning and I was kind of okay. And then I walked to the health centre and they gave me treatment. It's just like, oh my. So yeah, it's really difficult.
Yeah. Wow. Yeah. Okay. Enough of my tangents then. So back kind of to the actual numbers you're citing. So, okay, here we have in early 2023, you said that the cost-effective estimate for OneDay Health meant that on expectation, you could save a life for under $1,000. Now, so for those who are familiar, there's a charity evaluator called GiveWell, and they basically try to evaluate the cost effectiveness of different charities and determine how much money it would cost to save a life using like different interventions. So basically, their like current bar for cost effectiveness is like they currently estimate you can save a life for around 3.5 to 4K. So your 1,000 estimate is like well below that. And I was just kind of curious, like, yeah, how did you come to that number? Has there been any updates since?
Yeah, I mean, we haven't done another one. First, I really want to say that, like, GiveWell are very conservative with their numbers, and it's fantastic. They do big discounts. You know, they, like, basically anyone who takes, like, their cost effectiveness assessment and then GiveWell does it, GiveWell are going to be, it's going to be way more. And, like, this is just our initial cost effectiveness estimate. I'm sure we haven't discounted enough. I'm sure it's probably much more than that. This is just what we kind of came up with on paper, but on like a really kind of intuitive level. Like if one of our health centers can save one life a year, so imagine across, or like the equivalent, you know, you add up all those little, you know, like improvements to people's lives of, you know, a month or 3 months. And like if we can have the equivalent of kind of 30 extra good years from one of these OneDay Health centers across, and that's going to be across something like 1,800 patients a year, about 2,000 patients a year, then it's going to be somewhere in the realms of $1,000 to $2,000. So on a really intuitive level, like I think kind of the equivalent of one life a year for a health center is kind of makes some sense. So I don't know if I'm allowed to be saying this, but actually at the moment, Ambitious Impact is doing a bit of an assessment and doing their own cost effectiveness analysis right now, which is really cool.
Nice.
And they're doing a completely different methodology. So one of the problems with things like this is methodology is really hard because most of what GiveWell do, they do a big randomized controlled trial on their interventions. So they really have an accurate idea, a pretty accurate idea of how much it costs. Like if we give, you know, 1,000 mosquito nets, whatever, we save one life, whatever it is, you know, something like that, 1,000 mosquito nets for one life. And they are pretty confident about this because of a lot of big studies. But most small interventions, they haven't had this research. Like we haven't had like a $3 million randomized control trial looking at what we do. And so we have to make a lot of assumptions about, you know, what does it mean for people to access healthcare faster and with better quality? And we kind of mash some global burden of disease statistics together and say we can make a bit of a difference here. So we make a lot of assumptions because we haven't had like a big trial specifically on our intervention. And most interventions are in that boat. And I just to push a little bit on this, like I think this is one of the big advantages that I think Give Directly has. So Give Directly, when they give money, they're finding all these extra benefits. When you give someone money, you don't just get the benefits of them spending that money. Maybe they go to health centers earlier, and so they reduce maternal mortality, or people get more food to eat. But part of the reason they can see this is because they've just studied everything. Like they've got all this effort and all these researchers. But most interventions don't get to do that. So I think you get like a research bias. The more you look at, the more you actually see. And so we've got to be careful looking at some interventions that have been heavily researched and being like, well, these are kind of more effective and have these side benefits, because a lot of other interventions might as well. It's just that they don't get the opportunity to look at that, which is interesting. This is not just me as a small intervention being bitter. No. Maybe it is a little bit. Maybe it is. But anyway.
Well, this is part of why, I really wanted to talk about this, because it's, it just feels a little bit strange that obviously, because GiveWell does these big randomized control trials, and in that sense, it's quite slow moving, even though it makes little tweaks all the time to its recommendations. It's always doing kind of like smaller trials and explorations and stuff. But its kind of top charities list changes very slowly. Obviously, that's not accurately tracking what the top global health charity in the world is. And I did wonder a bit about that kind of difference between, you know, what would it look like for your charity to be assessed by GiveWell or something? How does that even happen? Like, is this, they just have to become convinced that there's something there and then they fund a massive control trial? Like, I mean, the class of charities that yours is in must be so big that they can't really assess all that many of them. So, yeah.
Yeah, and I'd say it's in the same as, like, there's a great organization called Charity Entrepreneurship, which launches a lot of charities, and they often have decent data behind them, but they're launching 12 a year, but none of those charities would usually have the data behind, or often, maybe a few of them would, but most of them wouldn't have the data behind them to be considered by GiveWell. I want to say that most of the GiveWell top charities actually had the research behind them before GiveWell came in, if that makes sense. So GiveWell didn't fund the research. which gave them that status. And I think that's correct. Because GiveWell, I think what the beautiful thing about GiveWell is it's a pretty sure bet. So the idea is not that they have the foremost cost-effective charities in the world. The idea is, and I think sometimes it's framed wrongly, like, oh, GiveWell has the most cost-effective. That's not what they're shooting at. What they're aiming to do is saying, like, if we take the charities that have the best evidence behind them, so charities that already have truckloads of evidence, among the ones with truckloads of evidence, which of those are the best? I mean, there could well be 20 or 50 charities in the world more cost effective than the top GiveWell ones, but there's not the evidence. And so I think what they do is correct. And it's not that intuitive, like that you take the ones with truckloads of evidence. And I think it's good that it's really slow to change. You know, I don't know if you know about like Chesterton's fence, this idea that like we should be very careful about moving away from the status quo. Because if someone like me, $1,000 per life saved, I mean, it's probably not. You know, like you can't just take some new bit of evidence and then overweight on that to change things that you know very well. So I really agree with GiveWell's the way they do their top charities. Yeah.
Yeah. Interesting. I mean, so without this without all this massive amounts of research and kind of, you know, studying as much or more than you're actually doing the intervention, how do you currently measure your success? How do you know that OneDay Health is doing well? How would you know if it had a bad month? You know, what do you track?
Yeah, I mean, so on a bad month, that's easy. It's just how many patients are we seeing, and what are we treating, and obviously you have high performing health centers and low performing health centers, and then we have to figure that out. Also, we have the data on quality of care. So we look at does the treatment match the diagnosis, and then of course we do have these external studies. So that London School of Economics last year did some research using mystery patients. I don't know if you guys know about mystery shoppers. You never heard of mystery shopper? Wow. Okay.
Yeah, they like send somebody in disguise, or he doesn't reveal that they're
Is this
a lot
thing?
of big maybe a lot of supermarket chains do it, and they go in and they cause trouble. They're like, oh, this product's bad, and you know, can you help me out with this? And they be kind of a bit disgusting, and then they see how the staff interact, and they just send them around all these supermarkets like to see how good their customer. And so this is what we do. This is actually the gold standard for treatment quality. So you train patients, like fake patients, to act like someone with an STI or like someone with pneumonia. And there's certain conditions that you can act without symptoms. And this has been done all around Africa. And one of the big things is that, this is just a bit of a side note, is that the quality of care in low-income countries is worse than you think. If you had to predict, like out of 100 patients that came in to like a clinic in sub-Saharan Africa, like what percentage of those you think would get the being very generous, the vaguely correct treatment for their condition? Like, what would you guess out of 100?
Well, I mean, I guess because I mean, what we've got from the data is that like a lot of the conditions, there are some like predictable conditions. There are like not that many that most people are coming in with. So you'd think that you'd get a handle on like the top 5 or something. So yeah, I don't know, like 50%, 60%.
Yeah,
that's pretty good.
I was going to be a bit higher. Yeah, sorry.
I mean, 50-60% is about the ceiling. Like the average is more like 1 in 3. It's consistently between 25 and 50%, even kind of with clinicians and doctors. So in South Africa, in Ghana, and Uganda, and all these settings. And in our case, we were a bit shocked that our nurses. So our nurses perform better than government, better than drug shops, even better than private clinics in town. But overall, they were only treating 1 in 2 patients correctly, like just around 50%. And this was a shock to us because we have very good supervision guidelines, and we should have guessed this because like your priors, right? Like even more experienced people in other countries have scored lower. There was a famous one which was actually in the Lancet, like the biggest in the world, in India, where they looked at ORS. Like people go in with diarrhea, fake them, and then do they give them? And only a quarter to a third of them got given ORS for diarrhea. And then they did a great test where the patient would show them the ORS on a smartphone. So if they said no, the parent would be like, but I need this. And that increased it to like just above 50%. But I really like that as an intervention. Like if you as the patient demand the correct treatment.
Yeah, I hate to bring up AI because we managed to get this far into the episode without mentioning AI, which is pretty exciting.
Wow. That's amazing.
But 30, I do now.
30 minutes, 20 minutes. And we didn't mention AI. Like it's the salve to the soul. Like let the cleansing water wash over me. You know. Anyway, carry on.
Yeah, so everyone could just sit in that feeling for a moment, but now I am going to mention AI. have you considered using AI to standardize care a bit more? Because I know that, I ask for like random stuff that I might want to ask a GP, and it does seem like broadly good, especially with like if you give the right kinds of information and prompt it in the right way. And yeah, I just wonder if that might be a bit of an unlock here because of the crazy stats that you're giving about like incorrect care. I feel like AI already is doing better than those numbers.
Yeah, I mean that's a great point. So basically after the study where it's like, okay, 50%. We're like, okay, I now feel better about using AI. So we actually were part of an accelerator last year, and we've got a huge advantage with AI, and we've got these clinical guidelines, these standard guidelines. So we trained an AI tool to basically constrain it to our clinical guidelines. So it's constrained to those, and it works really, really well. So we've kind of put it through 3 or 4 iterations. We've done some bot-on-bot kind of multi-turn training, and we're actually about to do a randomized control trial on it this year. So we're just trying to get the funding and get the setup. But we'll give it to half of our health centres, and half of them we won't, and then we'll send the mystery patients in. We'll send 20 mystery patients into each health centre, and we'll see if we can get that 50% up to 60 or maybe up to 70%. So I'm really excited about this. This is going to be one of the first trials of kind of clinical AI use in a remote setting kind of in the world. And we've got this gold standard kind of assessment, which we've already got set up to do it. So I actually think, like we say, one nurse in one room, but I think soon it's going to be one nurse in one room with AI. I think that's going to be the future, and absolutely
AI is the future?
There's no getting it.
Hearing it here. Hearing it here first.
No, it's like for this, where healthcare is this, I think we have an excuse. I mean, I was in a meeting, it's a classic thing with the OpenAI people who were funding part of this accelerator we were on.
Right.
And the classic line they said is, well, people are asking now, when is it ethical to use AI? But it's very soon, the question is going to be, well, is it ethical not to use AI in consultations? Yeah. And I think in places where the baseline is already really low, we need to be, and interestingly, there's a lot of the frontier research funded by the labs is in low and middle income countries. So one of the biggest studies was actually Penda Health in Kenya, and this is rich clinics in Kenya. And what they had is that so they write in the computer, right? The doctors. So it's much more advanced than our nurses in remote rural areas. And the AI just comes in. It's like, have you asked this question? And it's like, red flag, I'm not sure about this thing you've said. So the AI just gives advice to them. And this increased, I think, by about 11 or 15% improved their quality of care just by the AI giving them nudges, in the clinics they were in. And this is funded by OpenAI because basically in rich countries, you're not allowed to do this yet. Like, you basically can't have direct clinical decision support. It's not allowed. But in low-income countries, you can. So the labs are like, oh, wow, if we can prove that it improves care in low-income countries, then the rich countries will have no choice. So interestingly, a lot of the frontier research in healthcare and AI is actually happening in countries like India and Kenya and Uganda at the moment, even more than it's happening. Like, in terms of the practical use, there's lots of theoretical uses. So that's a really cool thing. Both cool and also a little bit nefarious because they've all got their motives, like maybe nefarious is the wrong word, but it's an interesting situation with testing AI in clinical use at the moment.
Yeah, I think I'd be more worried about it if I wasn't already confident that it's like pretty useful for like that specific use case. I mean, there's some big limitations. Just I'm getting excited. I'm supposed to wait, but I'm interrupting the host. This is terrible. You still have to get a lot of history and a lot of context. So if you just go on your phone and you're like, oh, I got a pretty bad headache, then it's actually very hard for the AI to get there. Like, it has to ask a lot of the right questions, and it can be misled. The other one, which has just proven to be bad, is edge cases. So, for example, on that case, if you say, I've got a really bad headache, but if you say, I've got a really bad headache, it means very different things. And what we've seen is on the severe end, like for emergency cases, at the moment on the edge, so it's AI does pretty badly still, right on the edge cases. It's better with common cases, and it's better with complex algorithmic stuff like cancer with a range of symptoms, or like heart disease, which has all these different inputs that come in, your blood pressure and your age and your lipids, and it's good at that stuff. Oh, it's so weird, the kind of jagged capability thing where it can be better at the things that you think are going to be the hardest to get good at, like cancer diagnosis.
I think, okay, I feel like Toby and I are both like overflowing with questions. But okay, well, I have two questions that I want to ask. So I'll just ask them. One question is, how often do you interface with the nurses? Like, I'm curious how much feedback you get from them and how often you like check in with them, basically.
Yeah, so their managers check in with them every week. So they call them every week and they visit physically every month and do an audit, and usually multiple times a week. What we actually found is that we need a lot more interface than we thought. And this is another thing that we're kind of hoping to automate a little bit, but I won't get into the details. But what we found is when we visit them every 3 months, the quality of treatment drops quite a lot. And so we kind of thought that we teach people, we supervise a bit, and then the quality will stay high. But it actually requires a lot of supervision. So the very best nurses, they stay very good at treating. You don't have to visit them much, it's fine. But a lot of nurses, like, it just helps to be supporting them a lot, because we're aiming for kind of the treatment to match the diagnosis correctly over 90% of the time. We can't be sure the diagnosis is correct, obviously, but to maintain those numbers, kind of weekly calls, monthly visits is what we've found keeps it there. So we've actually interfaced a lot more now than we did when we started.
To what extent do you think loneliness is contributing to that? Like, I wonder if morale just goes down when they don't have someone to talk to. I don't know.
Yeah, I mean, it's a good question. Like, is the quality of care related to morale? I'm sure it is a bit, but I think it's more related to just norms. Like, you've heard about these numbers.
Sure.
The norms of treatment here are just really... And the community also puts a lot of pressure. People come in and they demand a certain medication, which is often wrong.
Yeah.
Because the norm here is you go to a drug shop and you just ask for metronidazole. You just ask for malaria. You don't even get a test, right? And so, so we have to actually change the norms of the correct treatment.
Okay.
And so I think, like, that's a big part of it. I think morale could be part of it, but I think it's more like the way things are done is not often the normal, is not necessarily correct. And so when you're trying to continuously move people away from the norm, it's like inertia, right? Yeah.
That makes a ton of sense, that you have to just keep reinforcing it and being like, no, this is what we do. This is what we do. Yeah, that makes perfect sense. That's really interesting. Okay, my other question is, when I hear all this, I have some instinct that kicks in that's like, why don't you just scale this up and just like go and do like a bajillion health centers? But I'm sure there's like a reason why that's hard and not possible.
Yeah, I mean, it's a great question. I mean, so we were really ticking along, and it was kind of like a part-time thing, to be honest, for about 6 years. So I was being a doctor managing, and then I realized kind of 3 years ago, I was actually, maybe it was 4 or 5, when I was actually at Cambridge in an EA group, and I was like, actually, this One Nurse Health Centre thing is actually just more it's more important. It's going to save more lives than the other things I'm doing. So this is what we're going to focus on. So we've only been really, really serious for kind of 3-4 years. So last year we went from 50 to 75 one-day health centres, for example. So 50%. And this year we're going from 75 to kind of 105-ish. So we are kind of growing faster. But I mean, we think it's possible to like launch 100 in a year or something like that. So it is also possible to grow faster. So what holds us back is that we in Uganda, like, there's probably only about kind of 100 to 120, 100 to 200 of these healthcare black holes that we'd want to launch in, and we're on track to reaching them. So our dream next is like, can we find like a government department or a business in another country that says, okay, we've got 500 black holes here, can we fill this in a kind of 2 or 3 years? Like, there is still a practical restriction, of how many can we launch in a year? 100, 300, 500. I mean, I'm not sure what's possible with a scale up, but we're on track to that. Like, we want to be launching a lot more.
Okay, I think actually this might be a good time to move into like the next section, Toby.
Yeah, I mean, I did wonder, like, just one last thing on OneDay. How long until you like max out Uganda in terms of filling these black holes? Was that the one where there's like 100 spaces left or something?
Maybe 150, we're not sure. So maybe 3 years, 3-4 years. And so that's why we're starting to pilot in other places, which maybe have even more potential than Uganda. So Uganda's not necessarily like the best place to do this. It's just where we started. And we've done a big analysis actually with some master students from LSE looking at places where maybe OneDay Health could work really well. And there's a number of West African countries which have a high out-of-pocket spend for healthcare mixed with really poor healthcare outcomes. So we're looking at that. And we're actually piloting in Nigeria and partnering with a business, which is really cool. So we're going to launch 6 in a state in Nigeria next year, Akwa Ibom, with a business called MDA. So they run big clinics in towns. And so we're kind of looking to pilot in a few different countries and then see like where it works, like where our model actually works, and then kind of look to scale up either through the market or through government in those places. But we want to pick 1 or 2 countries where we can grow fast, like where we can kind of launch 200, 500 in kind of 3 to 5 years. When we don't want to grow incrementally in other countries, we want to find places where we can kind of go big pretty fast. Yeah.
Nice.
Nick, how big is your team?
Yeah, so we have 6 people on top, like kind of executive management, COO, CTO, data stuff, finance, and then we have 11 managers and then about 90 nurses, maybe like 95 nurses. So it's like about 110 people in the organization. Yeah.
Yeah, wow. It's like really interesting how you're managing these partnerships and all these different, like scoping these different potential like ways to grow. It's like, yeah, it's really impressive.
It's interesting. And it's amazing. So this year, we're obviously doing growth, we're doing tech development. Our total budget for this year is $850,000, of which about half of that, just under half, is like recouped from the nurses. So our donor fundraising for this year is about $500,000. So like it's all being done with a lot of stuff with not very much money, which is great, and that's obviously how we want it to be. And we're going to increase that spending over the next few years. But I kind of surprises myself how we can do so much with so little.
Yeah, absolutely.
Yeah. I think my kind of like final one day question is how could an interested listener help you scale? Because yeah, I mean, thanks for coming on this podcast, and I feel like it just sounds awesome. Maybe there's someone out there who can help. So yeah, is there what's your bottleneck right now?
Yeah, we have a few bottlenecks. So a big one is that our model of 1 nurse in 1 room, as in a rented room, as just a way of doing healthcare, is not well known and accepted kind of around the world and around. So a bottleneck is kind of this. So if we go to a government and we say we can do this, they'll be like, that's weird. It's a rented room. How's this going to work? Like, I don't. So just it being like an accepted and known entity. So that's why we're doing more research on it. And that's why we're like trying to promote it as like a super cost effective model. So just like how well it's accepted in the global health world is actually quite a big bottleneck. Obviously that we're just in Uganda at the moment, so it's great that we're getting into other countries to like unlock more opportunities. Obviously money is a bit of a bottleneck over the next 3 years. Like we're raising kind of 2 million over the next 3 years, expansion, tech development, management team, that kind of stuff. But it's some pretty niche stuff to help. So at the moment, Anthropic's doing this thing where they're putting an AI intern in your organization for like a year. And like I always say, like if you've got 3 months and you're really good with AI stuff, like, and we won't pay you any money, unlike Anthropic. But like, there's a lot you could probably do to help out. Like we want to make a full medical management system, like using AI, which we want to automate our quality checks so that our nurses can spend more time talking with the nurses and less time doing assessments in the books. So like, if there's anyone out there who like has 2 months, has 3 months, want to like intern and you're really good with AI, then I think that could be a really cool way to help. Also, like a niche thing, like if you're somehow connected to like some government in West Africa, or like introduce us to the Minister of Health. I mean, sorry, that's probably ridiculous.
It may as well. I mean, we don't know exactly who's listening to this podcast. One of the 60 listeners might be someone who knows the Minister of Health.
It could be the Minister of Health. You never know.
Yeah, true.
It could be. Oh, wow. You guys are ambitious. Your new podcast, and you're shooting high. I love it.
It went right to our heads. So yeah, those are. Sorry, continue.
My gosh, yeah. And so I mean, those are like a couple of things. And yeah, I mean those are like the kind of obvious ways. And obviously, if you've ever got any money to throw away, we're always very grateful. That one's probably pretty obvious.
Yeah, nice.
Yeah.
Okay, awesome. Yeah, thanks for that. As well as your work on OneDay, you also have written a bunch of great posts on the forum, many of which are not related to the idea of like one room, 1 nurse care, including so there was one I was interested in that you wrote a couple years ago about clean water. There's a study by Michael Kramer and some other co-authors which showed that chlorinating water in particular areas in Africa led to not just a 30% of reduction in diarrheal deaths, but a 30% reduction in overall under 5 mortality. You said, like, to put that in perspective.
A reduction in morality, Toby.
No.
Sorry,
I didn't even catch that.
mortality.
Thank you very much. Yeah, mortality, to be specific. Yeah. To put that in perspective, mosquito nets reduce childhood mortality by about 20%. And yeah, you also at the time mentioned a study of the RTSS malaria vaccine, which was associated with about 13% mortality reduction. There was a recent study that came out like last month, I think, where they replicated a pretty similar stat, where it's 1 in 8 deaths among children that they prevented just with the malaria vaccine in Ghana, Kenya, and Malawi, which is bonkers. So yeah, this post was a lot of you being incredulous that there isn't an obvious answer to the question of why is cleaning up the water that effective? Yeah, do you have any updates on that post? Anything you found out since that might help answer that question? It does seem so weird to me that it's like, is it a statistical anomaly? Is there something that's going to, in retrospect, seem obviously wrong here?
Yeah, I mean, part of the post was that, which is interesting, is that 100 years ago, like in Germany and in USA, like when they were starting to pipe water everywhere, they predicted that they'd reduce typhoid and they'd reduce mortality by 5% or whatever. But they found independently in Germany and in USA almost the same thing, like 110 years ago, like a 20-30% reduction. And so there was this paper like called the Mills-Reinke. The guy in Germany was called Reinke, the guy in I think America was called Mills.
Yeah.
And so they found this mortality reduction 100 years ago, and it was the same as what Kramer found when RCTs come out like 100 years later. So I think that makes it less likely to be an anomaly and more likely to be a real thing. Obviously, things are getting better. Water's getting better. I think now, these things are always reducing. Maybe if you do it now, it's 15%, but it doesn't matter. It's a lot. And the answer is that it's great. I did a really fun post, completely non-influential. I think we're just no closer 2 years later to having any idea why. And my point is like, why does it matter? We know what. Well, I think it does matter because there might be something about it which we could utilize in other ways. Like, let's say it modifies our gut flora. Then, and that's the reason. Well, then maybe there's some other ways we could do that to reduce. Maybe it's all about the transmission of disease. And if you ask me what's the most likely thing, like what's the most likely reason, I think it's probably just spread of infection. So like having clean water around can stop pneumonia from spreading, even can stop typhoid from spreading, like neonatal sepsis around birth. Like neonatal stuff is a big cause of child mortality, and that can be reduced just through washing hands and spread of infection. So I like, if you ask me to guess like what it would be, and it's just a complete guess, I'd guess a lot of it would just be about not clean water and diarrhea, but clean water just stopping spread of infection. But it could be something completely different. And I'm still, maybe there's people looking into it now, but I feel like scientists could have a crack at this one. You could have a better crack at figuring out this bizarre thing.
I mean, I was feeling, it was interesting reading that post again, and then also thinking about this malaria paper, because I was thinking about it for the EA newsletter this week. And it's, I think that was also, it's very odd because, 1 in 8 child deaths, like 1 in 8 children in these areas do not normally die of malaria. And yet it is reducing child deaths by that amount. And like, one of the reasons that is given is that, there's people who have recovered from malaria who then are more susceptible to other things, or like people might actually have malaria more in those areas than we think they do. But I wonder if it's just this thing of like, there's a fairly limited stack of causes which are making it likelier that you die before you are 5. And if you take one of those out, then you get that big change. Even if like that many kids are not dying of diarrhea caused by disease in the water or something.
Yeah, I mean, I'm going to push back on that a bit, actually, Toby. So I think with the malaria thing, we actually know basically why the 1 in 8. So malaria makes you weaker. It also causes anemia. It reduces your immunity. So anemia is a really big deal in terms of protecting from future infections. And I mean, I've had malaria really whacks you back for quite a while. And I think so we can almost understand why the 1 in 8 figure. Also, I want to say that 1 in 8 figure is a little bit speculative. It's not like exactly, it's not like, that's not a mortality study like these. I'm pretty sure it's not a mortality study like these water ones, which are actually looking at real mortality. I don't think, it's not an RCT. I think the 1 in 8 study, there was projections there. And even with projections, I'm a bit like, I think it's overstating. So at first I don't
really
believe
going around and asking people what their kids died of, I think. It was like... Yeah, that was
exactly, and it wasn't exactly, and it wasn't enough. So I think that 1 in 8 might be 1 in 15 or 1 in 20. It doesn't matter. The malaria vaccine saves a lot of lives, but also even if it is like 1 in 10, it can be explained. But with the water, it just can't. I mean, I'm a bit of a diarrhea skeptic. So everyone talks about malaria, pneumonia. I don't believe in it. No one really has diarrhea. No. So,
wow, that's a great tagline for the podcast. Thank you. Yeah.
Is this? Oh, sorry, guys. So yeah, it's immediately cancelled forever. But so basically, in our clinics, as a doctor in OneDay Health, we see lots of really sick kids dying from malaria and pneumonia. And kind of in the global health world, the big three: malaria, pneumonia, and diarrhea. But we just don't see that many deaths from diarrhea. I actually think the global burden of disease quite heavily overestimates diarrhea deaths. I had a look into this as well, looked into hospital studies where they've actually classified the cause of death. And again, you see a lot of malaria deaths, a lot of pneumonia deaths, a lot of other infection deaths, and very few deaths from dehydration. Like in my 13 years in Uganda, I might have seen, I've heard of hundreds of people dying from pneumonia and malaria firsthand. I've heard of these stories. I might have heard of one from dehydration. And even if you look at the diarrhea figures, even if you do assume the diarrhea figures are correct, I just don't think that kind of knocking back the diarrhea can even get close to explaining this reduction in mortality. So I think there's a big difference between the water situation and the malaria vaccine situation. That we kind of understand the malaria vaccine one, and I still, even without the diarrhea skepticism that I have. What's interesting is we're going to and even on OneDay Health, it's diarrhea in kids is number 8 on our diagnosis list, or number 7. Malaria and pneumonia are 1 and 3, or 1 and 2 on our list. That's super. But diarrhea is just anyway. So just in my clinical experience, I haven't seen. Yeah. But people are saying, Nick, you're going to go to Nigeria, and in Nigeria, diarrhea is going to be number 3 on your kind of OneDay Health. So it's going to be interesting going to Nigeria and seeing if all of a sudden it's like a Uganda thing, and actually in a lot of the sub-Saharan Africa, diarrhea is actually this just everywhere causing big problems. Anyway, there's my diarrhea diversion. Get back to
I mean, maybe all those people are just being paid by big oral rehydration to say these things.
I've always wondered that.
No.
Yeah.
It's
I
so
guess
bad.
If I may then, if you were to be correct, Nick, would the thinking there be that the oral rehydration therapy is helping just because being dehydrated is very bad for needing to fight a disease? The idea is they're just dying from other things, but it looks like it's from diarrhea, or why would it be overstated?
No, so I think diarrhea used to be a huge deal. The ORS studies are very old. ORS works so well. It was a landmark discovery. So in the 70s and 80s and stuff, there's no question. And even now, diarrhea is still a very big deal. I'm not saying it's not a big deal. I just think it's overstated. So no, ORS works brilliantly, but and this is the problem, and it's even the problem with nets at the moment, is that once you've researched something to be effective, you can't research it again. So we'll never, we will not. It's very hard now to look at right now how many lives are net saving, and it's likely to be a lot less. And will do discount, but you have this interesting thing. You do your original RCT on something 10, 20, 30, and then it's unethical to ever do it again. So you can be certain at one point in time how much mortality you're reducing, and then you can never do it again. You can never actually be certain, and you have to extrapolate by differences in studies and comparing different regions. And so it's a really interesting phenomenon of research that when you've figured something out, then you can never again do the best study available on it, which is really interesting. Yeah.
Okay, that is really interesting. Yeah.
Menstrual cups. So this was another post that you wrote recently. When I mentioned to a friend in my office that I was going to be talking to you, they said that this is their favorite post that they read on the forum this year is your post about menstrual cups. So yeah, can you take us through the basic case for menstrual cups as an effective health intervention, and also the open questions that you've got that you'd like to see someone answer on this? Yeah,
well, it was super cool. There's this organization called Malago, which kind of became a fellow of 2 years ago. They were kind of a global health funder, or a development funder, you'll say. And I met this amazing woman, Era, who's manufacturing really high quality cups really cheaply in India and distributing them en masse. So this is what I really heard about. So my wife, and this is she's used the same menstrual cup for I think 16 years. 16 years she's been using the same cup, and it's amazing. And what I say is like, just on a really, again, I like really intuitive things. Like imagine if for $5 you could have an intervention which would massively reduce anxiety, like slightly reduce medical issues, allow more productivity, like every month for 10 years. And it cost you $5. And like on a really basic level, there's a huge amount of potential there, just because the cost is so low. And obviously there's a lot of cultural and other issues to get over, but just like this, something that costs $5, and in the moment, just the data, like the counterfactual is so big. At the moment, it's genuinely, like where we work, it's rags. It's mostly not pads, it's rags, right? And like you've got this $5 thing, which is just so much better hygienically, well-being wise. And I think also that part of the reason that it hasn't got bigger yet, this idea of cups, is there's a few interesting reasons. One is that there's a real, it's an interesting, and I agree with this, is there's this idea that obviously women should have choice around their periods, right? They should be able to choose what to use. So often when people go into like poor areas, they'll be like, you'll give people all the options. Okay, you can use tampons, you can use pads, you can use cups, because it seems wrong to not give people a choice. But there's choices sometimes like at opposition to utility, and it's a very hard question, and I don't know. Eero, who makes cups, is like, this is ridiculous. Cups are just so much better. Like giving choices, like giving people worse options, and it's so like, what do we? And so that's one barrier to it. Another barrier is actually a research barrier, and that, to be honest, like I wrote this in my post, the research has not been amazingly positive for some of the impacts. One of the shocking things, and this is for all period products actually, is that girls don't necessarily stay in school longer when they're given period products, which is really interesting. And part of it is because school is just a really hard place to use period products, I think. Like it's these boarding schools, like the hygiene and it's very, very difficult to wash for like just getting tampons. It's very hard just to use, even if you have them, to use them in these boarding schools. And part of it is that like in boarding school, this is what Eero would say, is that in boarding schools you don't have this kind of rich, you're not talking to your mother, to your grandmother, to the community and figuring it out together. And so it's actually like culturally a weird place to kind of introduce new kind of technologies. And so I actually think that there's a great opportunity for well-being research for cups, because what cups do is they like the big thing, like when I was like, Eero, what do women say when we ask them about the cups? They're like, it's amazing. Like we can dance. We can do heavy work. We can do all these things that even with like pads were harder for us to do. And that's something that you don't measure with the healthcare research. And also like well-being research kind of bundles multiple things together. So it bundles in kind of the money you save, makes you feel better, the well-being you feel, even the health stuff. So like my kind of pitch is like, I'd love there to be some good well-being research on cups. The big barrier is that the research just isn't good enough to say that we should go big on menstrual cups. And I mean, we might be wrong. Maybe it's not the thing, but I think at least we could do a really good well-being study where you give some women cups, and then you can measure the well-being even just around the time of the period. Like you don't have to do it the whole month, but like, okay, is this kind of moving the needle? And so that's like what I'd love to see, because if it did show a difference, I mean, the cost effectiveness, given that it's $5 over 10 years, like it doesn't take much of a difference for it to be really cost effective.
Yeah, even like a good like time use survey seems like, what are they actually doing with are they actually gaining time to do things, or is this just like, I don't know, ephemeral how they think about it or something. Another part of this that was really shocking to me, I just wanted to say before we move on from it, is the stat about, was it that like 1 billion women don't have access to like period products? That was just, like a quarter of all women. That was just, I mean, I'm sure stats like this, it's not like there's a census taker who goes out and checks, but like, it's a pretty crazy statistic.
Somewhere between 500 million, and if you live in northern Uganda, like where OneDay Health centres are, it feels like more than that, because it's just the vast majority of people. So where you are, that seems very hard to believe. Where I am here, it's just like, oh yeah, that kind of makes sense. Like most women don't have access to it. So there's a lot of women who aren't so fortunate. So like it's like a lot of it depends on where you're living, how much a statistic like that kind of rings true, I think.
Yeah, that makes sense. It was shocking to find out too. And like even just thinking about how like periods are already such a like difficult thing in like developed countries and like among the middle class, like I have access to all period products and it's still such a like problem headache for me. And like most of like my friends. And then to imagine like literally just not even having access to the products is like just, yeah, it's like, so I totally like, I feel the same thing with the cups where I'm just like, if someone could just go to like a health center and you just give them the cup and they can have it for 10 years. And like, as far as we can tell, actually, I'd be curious for your take on this, but like hygienically, it's seeming pretty good. Like there haven't really been much reports of like toxic shock syndrome or like things along those lines.
No, they just don't have the toxic shock problem. There's been a lot of research and it just does not seem to be a problem. And part of it, I think, is the nature of this medical grade silicone. It just doesn't have that same effect as a tampon and being able to harbour things and cause that problem, if that makes sense. Which kind of makes some intuitive sense, I think. Yeah.
Yeah, totally. It's just like not absorbing anything. It's just kind of chilling. But yeah, I mean, that's like huge.
It's just chilling.
It's just chilling. So yeah, I mean, feels like a real win. But yeah, I'm glad you wrote about this. I'll be following it closely to see if this book, like if it takes off at some point.
Yeah, I've called Michael Plant. There's this guy who works in wellbeing called Michael Plant.
Nice.
I'm like, Michael, can we get a wellbeing study? Oh, we don't have the resources anyway. Shout out, like, can he hook us up with some researchers in wellbeing who can do a study on cups?
Yeah.
So what we're doing some distributions through OneDay Health. Like a bunch of our nurses are already using it, which is cool. And it's like obviously and so that's going to be really interesting to see how this goes in communities that have never heard of, like our nurses had never heard of them before. Like 1 out of our 15 nurses had even, so in these remote rural places. So anyway, it'd be interesting to see how that goes. Yeah.
Yes, very interesting. Okay, nice. Okay, now we're into the miscellaneous portion of the podcast. So we have some miscellaneous questions for you. This question's actually really lovely, and I think it was asked by JD Bowman on the forum. So it was just, how has having a kid changed the way that you think about doing good?
Yeah, so we had a really rough time. We decided to have our kid in the hospital I worked at 13 years ago. And so I'm thinking about writing something about this actually, but I'm not quite there yet emotionally. So basically everything went wrong around the birth. The baby's head came out after my wife had been pushing for too long and then got stuck. So it was just kind of worst of both worlds because the head is out, so you're exposed to the outside plus is stuck. And so there was an emergency C-section. And then he came out, couldn't feed, got jaundice, maybe got sepsis, and was in this NICU, which is nothing like a Western NICU. And we had this private room in the hospital. And in this private room, it's like quite nice. There's 2 beds. Okay, it's not nice by Western standard, but we have 2 beds and we have like a toilet with a shower. Like we don't have running water at home here, so having a shower was nice. And then you open the door, and to get from our room 50 meters to the intensive care unit, we have to step over about 50 women who are lying on the corridor of the hospital because these are the helpers for the women who are there, and they don't have a private room. And so it's this incredible thing where on one hand I'm like, oh my goodness, I'm so grateful that we have this room with 2 beds, to help look after our sick kid. And on the other hand, I'm like, why on earth are we here? Why are we not in New Zealand?
Right.
Like, so I'm feeling double guilt. Like, guilt from not using my privilege properly, and then guilt from like, oh my goodness, we're so much better off than all these people. And it was really rough. And I mean, the long story short is that it's just made me more motivated, like if this is what we experienced and this emotion and this pain and this, like, what are people experiencing all the time when their kids are getting sick and when they have to go 15 kilometers to healthcare, when they're like, it makes my work much more real. Like, I'm not actually kind of the most emotionally aware person sometimes, and so like feeling this deeply, like really deeply, like has actually made me more motivated in doing what I'm doing.
Wow, thanks for sharing that, Nick.
Yeah, beautiful.
Yeah.
And I feel really struck by that kind of like very natural human instinct where you just want to give your family everything, and to have to be in this position where you're both like, oh my gosh, I feel like I have more right now, and I just feel like it's still not enough because this is my family and I just want them to have like everything in the world. Yeah, that's beautiful.
100%.
Thank you, Nick.
It's tricky because all my other questions are far less serious than this.
Yeah, it's like kind of awkward now. No, I'm just
It's
kidding.
okay. No. You don't fire away, man. It's all good.
Well, one of the questions I had was there's mangoes versus fongos. So mangoes it's a term for multi-armed NGOs. People also call them bingos sometimes, like big NGOs, although there's some overlap. And then fongos, which would be focused NGOs. And you seem pretty strongly on the side of focused NGOs. There's a quote from you that the most effective orgs do one thing well for a long time. Think Against Malaria Foundation and new incentives. And this was from a recent post that we'll link. But yeah, I thought it'd be fun to ask you, what's the best case you can make for funding mangoes instead of fongos? So the opposite of what you believe.
Yeah. Man, this is pretty easy. I mean, because obviously, like, GiveWell does a lot of this, and I mean, GiveWell is actually funding more and more mangoes over, like, the multi-arms over the focus ones. I'm actually going to write something about this soon, but they're moving more and more that way, and obviously they've got very good reason for that. And so, yeah, I mean, I want to preface this that I'm going to make a great argument for this. So this is not what I believe, and so don't. I'm worried someone will quote my argument here. No, So there's a lot of good reasons. So first, big multi-arm, they're going to have a great leadership team, right? Because they're a big organization, so their top leadership is going to be on the ball. They're going to be able to, like, communicate with them well, figure stuff out. Second, they've got a long track record behind them doing multiple different things. So, like, you know that they can roll things out at a big scale. And the scale is really important here because, like, a lot of smaller organizations, you just can't deploy $5 million. Like OneDay Health, right now, we couldn't just go and launch another 500 OneDay Health centers, but maybe there's like a massive NGO in a country that, like, they could take our idea and they could roll out 500 big health centers much quicker than we can. So, like, if you want to do something fast and big, like, often you need to go with a big org. Also, I think there's an element of kind of de-risking because you've got an org which has a reputation behind it. So if something goes wrong, like, you look at them. So, like, with this, there was a big issue recently with water sanitizers and it didn't work out. And there was a very good campaign to kind of share the responsibility, like, mainly put it on the big organization. But if you're a big funder and you're funding a small organization, then, like, maybe the responsibility falls back on you and not the big organization. And so, like, but I think the biggest one is that scale. Like, you can do things fast, you can do things at scale. So that organization has connections with government. It has connections with the people in all the states. You've got the team on the ground that's just ready to go, right, to do the big rollout. So there's a lot of great reasons to do it that way.
Okay, that's quite compelling. What is your what are you hiding? What is your true case for focused NGOs? Why do you think on the margin money should go to focused NGOs or mangoes?
I think more than on the margin it should go to focused NGOs. I think there's just so much value in doing one thing and iterating and getting better at it for a very, very long time. Like, recently with this dispensers issue with Evidence Action, they're a big organization and, like, they haven't got a 5-year history doing dispensing. Right, and so they kind of subcontract another organization that's better at it. And basically, what went wrong there is the intervention was having chlorine in the water, but the chlorine wasn't in the water. Like, it was in a quarter of as much water as it was supposed to be in. Right, like it's like this wasn't like a big, like, complicated monitoring and evaluation thing. It just didn't happen. Yeah. And if an organization had been already doing that and figuring out the problems and getting better at it, then so. The big thing for me is, and if you look at the history of NGOs, I think even outside of effective altruism, things like Doctors Without Borders and Greenpeace, they've kind of stayed the course and stayed very effective in focusing on what they're doing. So for me, the biggest thing, it's like jack of all trades versus, like, master of one. And I think if you compare it to, like, in rich countries, we wouldn't allow NGOs to do all these different things. Right, you don't see this in Western countries. You don't have, like, a World Vision in America that does, like, we're doing cancer research and we're doing housing for people and we're doing, like, it's and so we have different standards for what we'll allow in rich countries and then in poorer countries, because, like, it's just understand, like, you in a rich country, you only have the experts and people who have been doing it for a long time doing that particular intervention. But for some reason, we think that project officers, can roll out, like, generalists can then all of a sudden do focused interventions. I mean, this is just the strong argument against. I think, like, there's very good reasons. Also, just my experience has been that all the big NGOs, this is part of what got me into effective altruism in the first place. I'd never heard of it. And, like, I was in northern Uganda and I just saw World Vision save the children, feed the hungry, I saw them all do all these interventions around me in my communities and reporting these great reports. And, like, nothing was changing. So I actually was getting disillusioned. And then this guy was, there's this great book called Doing Good Better. This is, like, kind of 7 years ago or something. And I was
Nice.
like, okay, I'll read that.
Yeah.
And so like part of me coming to so there's an emotional thing as well, because part of me coming to effective altruism was seeing these mangoes just like fail really badly. And I used to give my money to World Vision and Tear Fund and stuff, and then to come here and see them like trying to do all these different projects really badly was like it really hurt me actually seeing that happen. So like part of it is like being overly probably flavored by personal experience as well, which I think we're all guilty of.
No, it makes sense though, because it is like, because you get those, you get companies that, I was trying to think of an example, like was it Yamaha that makes like keyboards and also yachts or whatever, or you just have these companies that do like several random things, but like, I mean, maybe Japanese Zaibatsu aren't a good example or something, but like the companies that like they at least have the profit feedback thing, right? So they know that if they go into a new market, or they they know that
I'm gonna
it
say
will work, or that when it does
100%.
work.
And they're the exception rather than the rule. So we know about them because it's like, oh, it's weird that Hyundai like do the phones and cars or whatever. So like most like McDonald's doesn't branch out and do other things. Like Walmart doesn't try and sell what they try and sell more. Like everyone is mostly trying to do one thing and not branch out very much. So like even so I think like the reason why for me is more that those things are the exception, and we know about those exceptions being very good at it because there's just not that many examples of businesses doing multiple things very, very well. Yeah,
I think that's really valuable, like to hear your firsthand experience too. Yeah. Oh, well, first I just want to say, Nick, thank you so much. Like, I found this so interesting, and I just really admire your work and the way that you approach it and think about, like, problems. So, yeah, thank you so much for everything you share on the forum, for talking with us, for your charity work. Okay, now I have to get into the most important questions, and we have two of them. The first one is, if you could clone yourself, would you? It's free.
No.
Yeah, that's it.
No. Toby, can you imagine having to manage two of me on the forum? It would be impossible. Sorry.
I just
is
banned
it a
one
sock?
of them. It's fine.
Like, is it a sock puppet account if it's your clone? Like, if you're talking to your clone back and forth, is that allowed on the forum?
I think.
I'm sorry.
I think there's a branching thing, right? Like once there's a day or so, they've got like different experiences. They are technically two individuals. I probably can't ban either of them on the rules, so. Yeah, unfortunately.
No, I mean, and for me, like, just as a really simple thing, it's like, for me, it is eugenics on a really simple level, right? Like, trying to clone some people over others. And, like, it's very, very low, like, obviously the beginning of it. And that's the basic reason why I don't like it. It's very simple.
Interesting. This is a button that you press this button, it's an instant clone of you, it's free, and no one else has access to this button. It's just you. And and you wouldn't clone yourself.
No.
Reasonable. I think I agree. But is there anybody you would clone?
Like, because of eugenics, no. But like, if I was going to put that aside and think like, who would I clone? It'd be my heroes, really. Like, my heroes I have two opposite heroes that I would clone. One of them is Paul Farmer, and he was like one of the most influential people in global health. Like, made huge progress in things like TB and HIV, and just inspired a generation of people to think that healthcare is possible in these places. So that'd be one. And then my second one's the opposite of this, called Edric Baker. So he had this global influence. I've got this other person Edric Baker. He started a hospital in rural Bangladesh, and his whole life he just committed himself to one community. It's like the most non-utilitarian thing you can imagine, but it's just beautiful. It's just absolutely beautiful. And like, I'd clone him, and then they can make one other hospital, and it can be a beautiful thing as well. And these are kind of the two parts of my soul which I battle, is like the community and then like the utility. But yeah.
That's wonderful. I almost don't want to ask, but how many times would you clone them?
Just once.
Just once. Okay.
Just once.
I feel like that's a bit harsh on the world. I don't know. It sounds like they do a good job.
Yeah.
But Nick's trying to be responsible. It's a big thing, cloning people. Probably.
Yeah, true.
Probably.
I have to assume.
Yeah. Interesting. Yeah, that's food for thought. Thank you, Nick. And yeah, I mean, always our final question on this podcast. We can say now because we've answered it once before.
Can the world be better?
It's just so obvious. It's like, I hope it's already a little bit better after this conversation, guys. That's what I hope. But I mean, like, it's just so easy for me because I see things get better every day here. You know, like with each new OneDay Health Centre, you know, we say we're one step closer to that one day when everyone has healthcare, and it's like, it's just for me, this is like obviously if you didn't believe this was true, then what are we doing? And so like it's just it's a really, really basic and resounding yes, and I think everyone knows that. That's kind of the beautiful thing around this question. Like even the most skeptical people will be like, oh yeah, the world sucks, so of course it can be better, and then optimists will be like, oh, it's been getting better for ages and it can be better. So like I think this is something that people can agree on, even like with very different perspectives on the world.
Nice. Oh, that's brilliant.
I like that.
Yeah, it's a great answer. Thank you, Nick. Thanks again for coming on the podcast. Yeah, it's been great to have you as a guest. I think this has just been a super interesting episode, and yeah, no, thank you so much.
Thanks, team. It's been a blast. So much fun. Love it. Have a good morning. Have a good evening. Cheers.
Thank
Cheers,
you.
guys.